Acute heart attack, or what we medical terms call Stemi, that is ST elevation myocardial infarction, is a huge problem in this country. There is a 3 to 4 times rise of both in urban and rural centers in India. And what we think is that there will be approximately, this is a guess estimate, about 3.5 to 4 million patients with acute heart attack in India currently. If you look at it as is it growing, these number of patients? The answer is yes. It's about 3 to 4 fold increase both in urban and rural India. The other important point is that diabetes and hypertension, which are one of the predictors of this problem, is also growing. And as you know, with China, we are the diabetic and hypertension capital of the world. And this creates problems of increased incidence of this disease all over this country. Well, if you put these numbers in a perspective, we have about 3.5 million patients with acute heart attack or STEMI, while the US data is 0.3 million patients with STEMI. So there's a 10 times more incidence of STEMI in India as compared to the United States. The other major difference is that from many data, we see that at least 1/5 the patients who come with acute heart attack, at least in studies which we have done in our hospital and other parts of this country, is that many of them are less than 40 years of age, which you'd rarely see in a Caucasian or an American population. The most important thing for acute care of a heart attack is a system. A system means that in the US or Europe, if you have chest pain, a fire, or a theft in your house, you call a number, and that number in the US is 911. Immediately either the fire or the ambulance or the police comes to your place. While in India, we don't yet have a very organized systems of care, though now we are seeing it, at least in the south of India, slowly programs coming up for acute heart attack, some of which I have been involved with, which in Tamilnadu state itself, called the Tamilnadu Stemi project, with a 108 number where you call a governmental ambulance for an acute heart attack, which comes and picks up the patient from home and then transports to the nearest hospital which can deliver good acute heart care. You know, 3 major participants. One is the government. All systems of care have to have complete government participation, because otherwise the system will fall through if it's only private players or not-for-profit groups. The second is an ambulance service, which has to be a governmental ambulance, and the 108 is a classic example of where you can push the ambulance services up. And third is the hospitals and the doctors. The hospitals have to participate in a way, what we call as a hub and spoke model, because every hospital cannot be a tertiary care hospital. It can be a primary care hospital. So the basic treatment is done, the emergency care is done in the small hospital and then transported in an ambulance service to a bigger hospital which completes the care with maybe an angiography or angioplasty or surgical treatment. Unless you have a systemized treatment, the mortality and the problems associated with STEMI will not come down. We have a successful project called the Tamilnadu Stemi project, which has now been published in the Heart and BMJ, and we are scaling the operations up both in Tamil Nadu and neighboring states of Telangana and Andhra Pradesh. I think it's a very good thing that has happened, because all over the world it is like that. The government dictates a cost at which is the highest price that the stent can be sold to the consumer or the patient. So if you cap it, then the price may be lower but cannot be above that. And I think it's a very important thing that good quality stents are taken, and number 2, they are capped at a price so that the patients don't pay too much. With the volume of patients in this country, I'm sure that this capping of patients will still not do harm to any industry. They would still have a huge amount of patient load to treat with. And I think this is one of the good things that the government has done in terms of STEMI care or acute heart attack care in this country. Well, in acute heart care, the role of assisted devices, both in temporary, is small. Most patients can be treated with a clot-busting drug, which is the streptokinase or tenecteplase, and or a primary angioplasty, which is the best care, but unfortunately cannot be given to all people, because we don't have tertiary care hospitals all over the country, and most of them are urban-centric and metro-based and does not provide access to patients. So I still think, at least for the next 10 years in our country, the clot-busting drugs will be the important drugs, and following which we should do an angiogram within 24 hours, so that the disadvantage of the clot-busting drug is that it drives away the clot, but the artery may reocclude after that, which an angiogram will help to ascertain whether that's happening, and if you can fix it with an angioplasty or surgery, if there are multiple blockages, will prevent a recurrence or a reocclusion. The second question is, what is the role of temporary assist devices? In this country, at this point of time, for general use, the only temporary assist device is the intra-aortic balloon pump, which is available, which is good. Though many of the data from many communities all over the world say that it's not so good, but we in our care use it routinely for acute heart attack patients who have low heart function. The second thing is, you can use devices called impeller, which are temporary assist devices, which can keep for 2 weeks and 1 to 2 weeks and then withdraw. But unfortunately, they're expensive and they're not easily available. Now, what about a permanent? Suppose you get a heart attack and your muscle is completely damaged, and despite the opening of the artery with a clot buster or medical treatment or surgical treatment, your heart muscle is weak, then we need to look at options. And there are two options. One is what we call as a permanent left ventricular assist device. These are now available, though prohibitively expensive. There are technical issues with it because of use, especially in a country like ours where you may have infections and the clot thinning drugs have to be maintained very, very aggressively and correctly, and if patients don't maintain it, they may land up with the device failure. And the second option is transplantation of the heart, which again I would say that Tamilnadu, where I belong, has possibly the most nicely networked organ sharing network program. And to tell you that in the last maybe 6 years in Tamil Nadu, 3,000 cadaveric organs have been harvested, many of them for the eye and kidney, but I will say in the heart itself there have been 130 or 135 heart transplants done in many of the heart hospitals in the south of India in Tamil Nadu. So clearly this is picking up, and that is a very good option, but again it has its own challenges of the medical treatment following it, the follow-ups, the infections and things like that. But cell therapy, which is called as stem cell technology, is another area which is now catching up. It is still more at the research level. It has not completely come into clinical applications in the heart, but I see in the next 5 to 10 years some applications coming in the heart for improvement of the heart muscle. Genomics is a very exciting area, but if you look at heart attack in particular, the disease is a polygenic inheritance of heart attack or diabetes or hypertension. There is no single candidate gene where you can say, like, this is a gene that causes the heart disease. There are multiple genes which gets expressed in these. So there's a gene profile which predisposes you to these diseases, but you have to have an environmental influence, like say obesity, sedentary lifestyle, to really push this gene to create the disease. So, but we still know that if you pick up families which have a prediction to the disease, we can tell them that, see, you need to be careful right from childhood, because this disease doesn't happen at 40, it happens when you're 10. So if you can bring the lifestyle story in early, get the children to eat the right diet, exercise more, and be careful, you may at least postpone the disease, if not prevent it completely in a population with a risk.